하나, 둘, 셋.
Hello.
안녕하세요.
A time of learning orthodontics with a cup of coffee. Ortho Barista Dr. Ji Dae-kyung.
Ortho Barista Dr. Lee Jungkook.
Today's Easy Orthodontics session. The topic for today is periodontal orthodontics. It's very broad and deep, but today I will try to present it as simply and interestingly as possible.
In today's session, I will focus on the theme of preserving and utilizing your own teeth as much as possible.
Now, let's move on to our regular corner. Would you like a cup of coffee?
However, today, we won't be having a cup of coffee.
We won't? I sang for nothing?
You did a good job. Just like trying to save and use teeth that are in poor condition, or planning to share ways to recycle coffee grounds in useful ways.
You all drink a lot of coffee, right? I'm also a coffee enthusiast, and as much as we drink, the amount of coffee grounds produced is said to be enormous. They say it's 150,000 tons per year.
150,000 tons is an unimaginable amount. Let me introduce some ways to recycle coffee grounds that are wasted in a way that is unusual in everyday life.
First of all, these leftovers are produced, and they can be used as interior decorations. They are called coffee grounds or coffee husks. If you add water and knead the mixture, coffee clay is born. So, you can make things like planters, pencils, and even coffee bricks from this.
It also has deodorizing effects. If you brew espresso at home and dry the leftover coffee grounds, then divide them into small packets, you can easily make a deodorizer. Additionally, if you pour water and coffee grounds into a frying pan and bring it to a boil, it can help remove grease. It has a lot of functions.
If you try this over the weekend, I think you might receive some compliments. Thirdly, coffee grounds also have beauty benefits. Due to caffeine's waste removal properties, they can instantly exfoliate dead skin cells from the skin or scalp. They are also said to help manage oily scalps, which is great, right?
Personally, I'd like to try washing my hair with it, since hair is important.
Be sure to share your feedback with us. So, we've explored some ways to recycle coffee grounds. Try putting them to good use and join in on improving the environment. It can be a meaningful effort. If you share your feedback, we'll select winners through a draw and give out prizes. Then, let's start the orthodontic treatment of the Lee Jungkook and Ji Dae-kyung.
For those of you watching on Dental right now, feel free to leave your questions in the chat box on the right. We'll answer your questions and also send out Starbucks coffee coupons to selected participants through a draw.
Yes, this April and May, we will select participants who submit the best questions and send them a special gift. Make sure to submit lots of great questions. Now, let's dive into today's topic, periodontal orthodontics, focusing on misaligned lower anterior teeth in poor periodontal condition, extraction, and prosthetics or minor orthodontic treatments. First, we'll talk about some considerations for periodontal treatment. If the periodontal condition doesn't improve and further tooth loss occurs, it can lead to pathologic tooth migration, as seen in the image on the screen. Teeth tend to tilt toward the area of the missing tooth and can also become excessively over-erupted. If you look at the image on the left, you can see a typical example of periodontal breakdown of these changes. When this happens, as shown in the image on the right, the posterior occlusion collapses and the mandibular anterior teeth begin to continuously hit the maxillary anterior teeth. As people enter their 40s, 50s, and 60s, this often leads to mandibular anterior teeth spreading apart or flaring outward. Today, I want to talk about a few precautions and principles to keep in mind when performing periodontal orthodontics.
Dr. G, you have been running your clinic for about 20 years now and you must have far more experience with periodontal orthodontics than I do and frequently collaborates with periodontic specialists. I believe he'll also be sharing some brilliant cases with us today.
I think I learned a lot personally while collaborating with Director Min Kyung-man of the Department of Periodontology, who I personally respect. First of all, there are a few things to consider. As with all dental treatments, diagnosis and treatment planning are key. The periodontal aspect is, of course, very important. Once the diagnosis and treatment plan are accurately established, the appropriate treatment should be carried out accordingly. Once the periodontal condition is fully treated, orthodontic treatment can proceed, but there are certain orthodontic considerations to keep in mind. If the periodontal condition is poor, the teeth become mobile, and the issues we mentioned earlier can arise. Therefore, it's crucial to carefully consider how to use anchorage and to determine the extent to which the teeth should be involved in the treatment. For the first case, 32-year-old female patient. The patient has moderately advanced periodontal disease. It appears to look somewhat better at first glance. Looking at the panoramic image, the maxillary posterior area is generally in poor condition, particularly the right side, which is much worse. If you look at the probing depth below, what do you think?
By the way, what is that digital measurement device?
Back in the day, we used to measure probing with something like a Florida probe.
Is it an automatic measuring system? I've never seen that before, actually.
Periodontists might use them, but I don't think orthodontists typically use them. Anyway, moving on, from an orthodontist's perspective, how should we approach the posterior area? A lot of thoughts come to mind in this situation. So, we send the patient to the periodontist to establish a periodontal diagnosis and treatment plan. This is an image after the treatment was done by the periodontist. The periodontist has been very proactive in the periodontal treatment, and they also have a strong interest in orthodontics, which has been a great help to me personally. How about if you see it?
The bone has regenerated quite well.
This might give the orthodontist more confidence when proceeding with orthodontic treatment. On the top left, you can see Dr. Min's splint, referring to the treatment by Dr. Min that I mentioned earlier. I think Dr. Min might be feeling a bit flattered right now.
You did ask for his permission?
After the broadcast, I'll give Dr. Min a call and let him know. With Dr. Min's methods, the splint could serve as a fixed appliance in orthodontics, and from the periodontal perspective, the splint can help minimize tooth movement and other issues, acting as a device to stabilize the teeth. Now, as you can see, orthodontic treatment has started. After the splint, you can observe things like the mobility of the teeth, probing depth, and other phenomena that occur as a result. Once the treatment is completed, the outcome shows that it was successfully done, and the patient has benefited from it. When treating periodontal patients with orthodontics, it can be challenging, and there are times when you might face a lot of complaints. However, there are also many rewarding cases. After all, we're helping to restore and reconstruct the patient's teeth through orthodontic treatment. If you compare this with the previous state, you can see significant improvement.
This is actually a treatment that can be difficult for orthodontics alone.
In some ways, there can be suggestions in the treatment options available due to the condition. But looking at this, don't you feel a bit envious of this?
Yes, I'd like one too.
It's from the past. If you see, I'm just going to give you another example. Earlier, in the final slide, I discussed anchorage. Here's a tip. If a tooth needs to be extracted anyway, consider placing an implant first. Then, using the implant as an anchor, you can apply an intrusion arch wire to the posterior teeth, which can help achieve anterior intrusion, as shown in the image. This approach can be effective in certain cases. Next is an advanced case. This patient has significant periodontal loosening, and it's actually a case of my friend from the early days of my practice. With this, my age might be revealed.
You started your practice at 34 years old.
Yes, that's correct. The patient came to me asking for implants because their teeth were in poor condition, but since I only do orthodontics, I couldn't perform the implant procedure. I referred them to a periodontist for treatment. Since Dr. Min has a strong orientation toward orthodontics, he referred them back to me after their initial periodontal treatment. As you can see, the patient underwent primary periodontal treatment. Now, after completing flap surgery completely, the patient was sent to the orthodontics department. At this point, how do you feel about the case from an orthodontic perspective?
If you look at number 46, the root is almost visible, so it's really not an easy situation for orthodontic treatment.
From my standpoint, this was a challenging case, especially since it was early in my practice and the patient was a friend. But, trusting Dr. Min, I decided to go ahead and start the treatment. As I mentioned earlier, we used Dr. Min's splint and involved minimal tooth movement to start the orthodontic treatment. It's a bit embarrassing to show, but back then, in the early days of my practice, I wasn't focused on saving anything, more like carrying over the experience and mindset from my training period. That's why I made the ABP appliance at that time. Anyway, I remember using ABP like this and gently correcting it with at least less trauma now. So, when I have to do this, I'm using an implant and using a splint earlier, so the posterior region is actually using well until now. This is the completed orthodontic treatment case. Thanks to this, my high school classmate has become a lifelong friend.
If you compare the before and after, just looking at the gum color, although I don't have extensive periodontal knowledge, I still believe it was a very successful case.
It's difficult to show the full depth and essence of periodontal orthodontics with just one or two cases. So, in order to share a broader understanding and orthodontic knowledge with you, we will focus a bit more on the entire mandibular arch and discuss cases with Dr. Jungkook. Before that, I'd like to mention just one key principle that should be followed when periodontal issues arise and orthodontic tooth movement is necessary. When periodontal tissues are compromised, the center of resistance for moving the tooth shifts downward, and the area of the root that needs to move becomes narrower. Therefore, you need to apply less force. At the same time, you will need to apply a greater moment to compensate for this. So, by thinking about applying slightly less force but more moment, you can realize that periodontal orthodontics isn't as difficult as it might seem.
It's challenging, but understanding the basics thoroughly is crucial. They are elderly patients. If you see it in the picture, here number 31 had a lot of mobility. In fact, it seems to be a very common clinical case. The patient was complaining from number 31, as it kept touching his tongue and causing discomfort. Since the mobility was so severe, we initially decided to extract the tooth. However, due to the misalignment of the anterior teeth and the lack of proper management, the gums worsened in a vicious cycle. After diagnosing the situation, we decided to extract number 31 and proceed with orthodontic treatment. Of course, I see orthodontics as just one of the options. There are other ones as extraction, bridges, implants, and various alternatives. However, in this case, we decided to extract number 31. After extracting it, we were able to use the space to align the remaining teeth. This led to a diagnosis that supported proceeding with partial orthodontics. Looking at the progress, it took about 6 months after the extraction. If you look at the final result, the teeth were aligned quite well. The main focus was whether the teeth would move properly, considering that it wasn't just tooth number 31 that had issues. Number 41 wasn't in great condition either.
As we saw on the X-ray, the maxilla also had significant issues. Did the patient undergo an implant after this, or was it priorly placed?
If you look at the initial photo, he had the implant placed 10 years ago. Yes, the implant was done 10 years ago, and as you can see, there was some mobility in the maxilla as well. As you can see, pathologic tooth migration also affected the maxilla, leading to issues like early contact and trauma. For the maxilla, the tooth was extracted and replaced with a bridge. Today, let's focus on the mandible, with the initial, final, and 3-year follow-up photos. Here, you can see that initially, the gums around tooth number 31 were in poor condition. After extraction and orthodontic treatment, the results were better than expected. The bone healed well, which I think is a positive outcome. The patient came back for a 3-year follow-up recently, and it seems to be a successful orthodontic result.
Did they have a bone graft? The bone appears to have healed very well.
I believe the surgeon who handled the procedure mentioned that a bone graft was likely performed.
Regardless, even at an older age, creating a good environment for orthodontic treatment is a highly meaningful option in itself.
The second case involves a 47-year-old female patient. I think it's a case that is common in clinical practice. This patient had a slightly poor periodontal condition for her age. If you look closely, there is a severe crowding in the mandible. The lower arch crowding was likely the cause in this case. The crowding in the lower arch caused the upper and lower front teeth to collide, which led to the overall space opening and the front teeth protruding. After a thorough diagnosis, we considered various options, and today I'll be showing cases that achieved good results through orthodontics. Most of these cases were treated with partial orthodontics. In cases where the gums are in poor condition, it's often better not to apply any significant movements to the posterior teeth. I think it's not really easy. Of course, we have to thoroughly prepare the anchor for that particular move.
It looks like a mandibular extraction was done.
Yes, most cases are likely extraction cases.
If so, regarding mandibular extractions, are there any criteria or considerations we should keep in mind?
Of course, what we need to consider is a consideration related to the overall occlusion called Bolton's ratio. However, in cases where the periodontal condition is poor, attempting to align all the collapsed and misaligned teeth perfectly to achieve an ideal occlusion often results in more harm than benefit. In many situations, extracting a single tooth and achieving a more manageable alignment is more appropriate. Of course, I believe diagnosis is key in such cases. For this patient, we proceeded by extracting one tooth and moving forward with treatment. As you can see in the progress, after the extraction, alignment is still ongoing. So, after a total of 8 months of treatment, we were able to achieve a result fairly close to what we aimed for. Of course, it's not perfect, there were some limitations. While it would always be ideal for orthodontic treatment to result in a perfect Class 1 occlusion, I believe that addressing only specific areas through limited orthodontic treatment can also be a good option. If you look at the progress, the main concern for me was how much the lower extruded incisors would actually intrude.
Didn't you use any auxiliary appliances like the ABP we made during the residency?
I proceeded very cautiously with a light force while actively managing the periodontal condition. This was because, without intrusion, it would have been impossible to prevent interference with the maxilla. Although the periodontal condition was not ideal, by adhering to the fundamentals of orthodontic treatment we've practiced so far in maintaining thorough and careful management, we were able to achieve a certain degree of intrusion effect. This is the panoramic X-ray taken after the treatment was completed, and it showed no significant issues. Also, I perform bacterial tests on all patients undergoing orthodontic treatment. We collect saliva from the mouth and send it to a laboratory, where a PCR test is conducted to examine 11 types of bacteria related to oral health and periodontal disease, as well as 2 types of bacteria associated with cavities and bad breath. We use this test for all our patients. In particular, for patients with poor periodontal health, this method is something I find quite interesting, and it also makes it easier to explain to patients. That's why I perform these tests.
As I briefly mentioned earlier, back in your time?
Yes, back in my time. This is the kind of test I conducted.
Seems useful.
Actually, I've been familiar with PCR testing for quite some time through this examination. But these days, almost the entire population recognizes PCR. It's not exactly a common term. The reason I find this test so beneficial is that we conduct it once before the patient begins orthodontic treatment, again after 2 to 3 months, and again after completing the treatment. This allows us to observe any changes before and during the treatment. Of course, we have other diagnostic tools like probing, but this serves as a valuable reference for tracking bacterial changes. The results I just showed you are from one of my patients. When the patient first received the test in January, you can see from this graph, here, where the yellow arrow is pointing, this was the result at that time. During treatment and toward the end of treatment, the results looked like this. To put it simply, you can see some improvement in the bacteria. Of course, this doesn't tell the whole story, but it can still be considered one of the diagnostic tools.
If you continue conducting these tests at the beginning, during, and after orthodontic treatment, you'd likely accumulate quite a bit of useful data.
Actually, I think there are 2 aspects to this. What I was curious about is that, before and during orthodontic treatment, the bacterial count would naturally increase because it's harder to manage the appliances. However, surprisingly, for about 8 out of 10 patients, the numbers have improved significantly. Of course, this could simply be just numbers, but most patients come in monthly for scaling, and the doctor consistently monitors them. Also, when undergoing orthodontic treatment, patients tend to think, I really need to brush my teeth more diligently, which likely contributes to this improvement. I concluded that these improvements are likely due to the patient's education, leading to better oral hygiene compared to before orthodontic treatment. Secondly, seeing these results can motivate patients. When they realize, I had this many bacteria, it often encourages them to manage their oral hygiene more diligently.
I think this is incredibly important, especially for patients, including children. These types of tests, which are linked to motivation, can be very useful not only for periodontal patients, but also for orthodontic patients. For dental clinics with many patients who visit regularly, especially those with a high number of follow-up cases, this can be an extremely useful tool.
This patient also has follow-up photos taken 15 months later, and based on the results at the end of treatment, good oral health was found to be maintained. Retention is always something I find very intriguing. Once orthodontic treatment is completed, monitoring retention for 2, 3, or even 5 years.
This is the same for all orthodontic patients, but especially for periodontal patients, we use a fixed retainer or a splint. When we explained that it can help periodontal health, it might be a bit reassuring for the patients. Don't you think?
Yes, that's correct.
Have a cup of coffee.
This patient is also a guardian of the patient. Usually, when the patient comes, the guardian is standing next to him and sometimes shows his case. It's a phenomenon that always happens. Most of the guardians are elderly and they always start counseling this way. Let's quickly see this case. Patients with the same pathologic tooth migration seem to have almost the same pattern. When the mandible shifts, it seems to cause some misalignment or spreading in the maxilla as well. This is a panoramic X-ray taken during the initial examination. If you look at the treatment process, from the first photo to the next and then the following ones, it took approximately 8 months. As for the alignment, the issue was resolved in a total of 8 months. This is the final result after the treatment. The main focus during the process was how to intrude the lower anterior teeth, which were protruding, and how well it could be achieved. We also paid close attention to any potential issues that could arise in the process. If we look at the vertical changes, this is the result. Ultimately, by resolving the crowding and addressing the vertical issues, I believe it will lead to better long-term retention. This photo is from a follow-up taken almost 3 years later. If you look closely, you can observe some slight swelling of the gums, and there are still some aspects that aren't perfect. However, if we hadn't done anything and the patient hadn't received treatment, what kind of result might we have seen now? So what I always emphasize is that orthodontic treatment doesn't guarantee perfect results, but it can still lead to good outcomes, and I hope it's considered as a valuable option.
However, in the case of periodontal patients, we primarily approach cases focusing on CC, don't we? Because of that, there seem to be many cases where we either cannot actively address vertical issues or simply don't address them. In cases like the one we just discussed, where there's a slightly deep extraction site remaining, retention becomes quite important. Any tips for such situations? Earlier, I noticed that you attached the retainer toward the incisal edge.
Of course, if that really interferes with mastication, it shouldn't be placed there, but even if only for a certain period of time, I tend to attach it in that position as long as it doesn't cause significant interference. While using a removable retainer is also an option, I prefer to attach it in that position whenever possible.
Thinking of it as a kind of splint.
This patient is also a patient's guardian. 54-year-old female patient, and her case was quite the hardest. In this case, if number 31 had significant mobility and was removed, it might have been better, as the alignment would likely improve. However, the tooth with mobility in this situation is number 41. Since number 41 has mobility, extraction would likely result in a significant defect on the labial side. While it's uncertain how much bone could be regenerated, it would also require significant movement of the teeth on the lingual side. This made it a challenging decision. However, since the other option was limited to extraction followed by prosthetic restoration, orthodontic treatment was carefully initiated instead. When it comes to movement, if you look closely here, I splinted the areas around number 3 and number 4. This was done to minimize any adverse reactions. Of course, I could have used a stronger anchorage, like a mini screw, but instead, I ensured a solid anchor in the number 3 and number 4. I secured it firmly, focusing on anchoring specifically to the 4 incisors, or rather, the 3 incisors in this case. I focused on creating movement only in the 3 incisors as much as possible. For this, I started with an initial wire of 008 nickel titanium, applying the gentlest force. The treatment was carried out very carefully for 9 months. Of course, this wasn't intended to be a perfect orthodontic treatment. I aimed for minimal alignment, focusing on achieving an arrangement that would be the most manageable in terms of maintenance and functional alignment. While dedicating more time and applying greater force could have resulted in a more rounded alignment, I approached this case with significant caution. This is the result X-ray. Since there are still many aspects to monitor moving forward, we're continuing with regular follow-ups. We also took a series of PA radiographs, and fortunately, the orthodontic treatment was completed successfully without any significant issues. Is it that I was just lucky? Thankfully, despite proceeding with a thorough diagnosis, there haven't been any cases of severe side effects or treatment failures so far.
It seems the careful approach has paid off. Was it in the first episode of Ortho Barista? I remember we once reviewed a case with a less favorable orthodontic outcome while examining a CT scan. It was a case where treatment had failed. When there is an active lesion, if it's not properly managed or treated, moving teeth in such conditions can lead to unfavorable outcomes. Orthodontists might be aware of this, or they might not, but ensuring a thorough and accurate diagnosis is essential. Using tools like CT scans to aid in diagnosis is crucial. At the very least, when there's an active lesion, it's critical to avoid moving teeth in that area.
That's why pre-orthodontic treatment must always include comprehensive periodontal care and any other necessary treatments. Additionally, apply light forces, secure anchors well, and minimize the number of teeth involved in the movement. Adhering strictly to these fundamental principles should lead to better outcomes.
Yesterday, we had a one-day seminar on clear aligners. How was it?
It's not yesterday.
It's okay to say it's yesterday.
Let's do it again.
Yesterday, we held a one-day seminar on clear aligners. Participants came from places like Namwon and Gwangju, and the atmosphere was truly energetic. It was a great event.
I think clear aligners are definitely an exciting treatment option, though I agree that there is still some debate about their application to every case. While it may not be suitable for all situations just yet, I believe the future potential is very promising, and it will continue to evolve and improve. The enthusiasm and energy from the seminar reflected that anticipation for further advancements. I share that same excitement and am committed to studying and working hard to contribute to providing better treatments for patients in the future.
I also think that while clear aligners may not completely reshape the entire field of orthodontics, they certainly have the potential to develop and make significant strides within their specific area. It was a day where I could see that possibility and potential for progress. In the upcoming sessions, both Dr. Lee and I will share interesting, enjoyable, and sometimes challenging insights on clear aligners, and we'll do our best to present them in an accessible way. After lunch today, I hope you all enjoy your afternoon consultations, and as we wrap up this session of Easy Orthodontics Ortho Barista, I look forward to continuing our journey together. Thank you.